DB05 is sort of a successor to KATHERINE, and TDM1 has been sort of the standard treatment approach for anybody that has residual disease having received neoadjuvant therapy. And it's a standard that we've, adopted because it was pretty compelling from the data that's matured over a long period of time. So once we were seeing the activity of T-DXd in a number of different settings, including the metastatic disease setting, it was sort of a natural question to ask, could you confer an even greater benefit by using a perhaps more potent, effective drug compared to TDM1 in that same setting? And DB05 actually demonstrated that. And again, these were higher risk patients, who went into the trial, and the randomization was T-DXd or TDM1. And the patients who received T-DXd had a meaningful and clinically relevant improvement in event-free survival, I guess around 8-9%. Mm-hmm. So that is not something where you have to squint to see the results. Mm-hmm. And I think as a result of that, I think most people now would adopt T-DXd for residual disease over TDM1. And TDM1 has sort of started to move back again and, where we think about using it. Mm-hmm. There are, of course, trials looking at other things, TDM1 plus tucatinib, other things that, may potentially still keep it around. But today, based on what we know in the approval and it's in guidelines, I would think about T-DXd.
Yeah. And I think the approval is very interesting. The approval is really for patients with any residual disease after neoadjuvant chemo. So how do we feel about that?
I think it's a good question. And, those patients with very small volume disease, negative lymph nodes, how much more benefit are you going to get with this compound versus the standard that we have, which is TDM1? I think the other thought process also is, what are these patients that we're treating as well? There's also significant toxicity that we do know that occurs with T-DXd versus TDM1. Toxicities are different, but there's also a higher chance of ILD in these patients with the number of cycles that they're getting, which is 9, right, in the adjuvant setting. So I think those things are also important. The data that we do want to see moving forward is the potentially brain metastases in terms of how that affected it, and then the more mature data in terms of disease-free survival beyond 3 years as well.
Mm-hmm, mm-hmm. And in terms of the patient selection in DESTINY-Breast05, I think it was intentionally designed to reflect this high-risk population. In my mind, patients with residual disease in general, I'm worried about. And so I think there are probably many patients not captured in the original study that could be candidates for this. I don't personally have a lower limit of threshold of amount of residual disease at this time that I would think about omitting it for. Curious though, because my thoughts are evolving on this, do either of you, are there patients you wouldn't approach with this?
Well, you think back to when TDM1 post-KATHERINE, we would see like one little millimeter or something. Now you're trying to be a purist and say, well, they should go on TDM1. But do they really need it? Right. And I don't think that the process in our brains is any different with T-DXd. If you had, a really fantastic response and you just had a little ditzel of disease, I might debate with myself whether they really need T-DXd or not.
Mm-hmm. Yeah, I agree. How about hormone receptor positivity? How does that play into it? You brought up earlier, we're expecting the PCR rates with the T-DXd neoadjuvant regimen are better, but we're still going to have a fair number of patients, regardless of their neoadjuvant regimen, that will have residual disease with hormone receptor positive disease. So how does that influence decision-making in this space?
I think those patients with high volume disease that started out, prior to their neoadjuvant therapy, as the way they were enrolled on the 05 study, I think those patients I would still consider them for T-DXd.